Magala John Paul is my name. From the thoracic surgical unit. So my role today is to present the surgical management of EMPYEMA thoracis. So as we noted, passing the pleural space will define your EMPYEMA thoracis. We must note that it arises as a complication of a vast array of disease processes. As we mentioned, could follow a pneumonic process, or a pneumonia in a patient, could follow a bronchogenic carcinoma being obstructive somewhere, could follow your iatrogenic intervention if it's not aseptically done, could follow trauma, and so a timely diagnosis and appropriate definitive interventions are important in these patients to prevent progression from the stages, as Dr. Ejani mentioned, from the exudative, fibrinolytic, and finally to the organization stage. So it's important that a timely diagnosis is made and timely or appropriate interventions are made, so that we don't end up with the final organization stage, which is very complicated, not only in its management, but also in morbidity and mortality, for that matter. So a little bit on the stages. I'm not going to a lot of detail, just a little bit mainly about the organization stage, which is of most importance to the surgeon, the thoracic surgeon for that matter. Fibroblasts will grow into the exudative fibrin sheet. And this sheet coats both the visceral and parietal pleura, creating that inelastic membrane called the pleural peel, which encases or traps the lung. If you notice, this patient that has been presented had a collapse of the lung. This we believe was due to entrapment by a pleural peel, pushing this lung to the more to the midline, and also that peel attached to the parietal pleura, causing thickening of your parietal pleura. This is what causes the crowding of your ribs. So when it comes to surgical management, the exudative stage is managed by thoracocentesis, but this allows me to emphasize that it's best done for mild and moderate effusions. If you have a massive effusion, it's preferable that you do a tube thoracostomy, adequately drain this pleural space. As you insert it, do it aseptically, it's very important. And also connect the chest tube to a underwater seal container. One thing to note here is the tube size, the chest tube size. It's very important. Sometimes we put very small chest tubes in EMPYEMA fluid, and these small chest tubes are going to clog. Okay, coagulum will form and will block the tube. What was initially an exudative collection will progress into your fibrinolytic and finally your organization phase or stage of the disease. Antibiotics that are preferably culture sensitive. Okay, it's very important. Then we'll go to the fibrinopurulent stage. Here, it is strictly an appropriate catheter size, which is a flexible pigtail catheter. This is mainly in the pediatric population, or a chest tube of appropriate size, I emphasize, and antibiotics. Fibrinolytics can be used also in this fibrinopurulent stage, preferably tissue plasminogen activator. This may not be readily available on the market, I'm not so sure.
Yeah, there.
Yeah, okay. But you have to be wary of some reactions in these patients. Some of them may bring about fevers, some allergic reactions in these patients. So these are done, the fibrinolysis is done repeatedly until you have clinical improvement in a patient, or your chest X-ray shows a clearing of your pathology in that pleural space. And finally, for the organization stage, we use, for the early stage of the organization stage, we use video-assisted thoracic surgery, where you can go in and disrupt these fibrinous adhesions and loculations to aid complete drainage. Okay? It also allows you to debride the parietal and visceral pleura in these patients. And VATS still aids accurate placement of your large bore chest tube. I'm mentioning large bore. You can see me emphasizing it at every point. Appropriate chest tube in appropriate drainage. If it's a clear effusion without pus, you can put a 28 chest tube, 28 French. If it gets into pus, you may want to move into 30, 32, 30, up to 36 size of the chest tube. For video-assisted thoracic surgery to be a success, it should be able to establish a unified pleural space. Okay, you're literally draining everything in that pleural space and achieving a total re-expansion of the lung, very important, with obliteration of the pleural space, which is the potential site for a reaccumulation. If at video-assisted thoracic surgery you find that the lung is entrapped, remember I mentioned that pleural peel over the visceral pleura, or entrapping the lung and over the chest wall, it's preferable that you convert from VATS to a thoracotomy. That's when you literally go in and do open surgery, preferably through the 6th intercostal space. And in this, decortication means you're removing that pleural peel off the chest wall, it's a parietal pleura, and off the entrapped lung. In removing this pleural peel, you're allowing the lung to re-expand and fill up that pleural space. And also relieve, as much as possible, removing or decorticating that parietal thickening the peel. You're also allowing the ribs to open up somewhere. Okay. Otherwise, if you leave the parietal peel on, then your lung will not be able to expand adequately, or that you may end up with a chest deformity in this patient. In patients with chronic EMPYEMA, if you notice, the side of the pathology will seem like it's not expanding adequately as the normal side. Okay. Okay. I think that does it. It must be noted that decortication at thoracotomy is a major operation and physiologically challenging to some patients who are compromised or debilitated. So if you think morbidity and mortality will prohibit this aggressive surgery of thoracotomy and decortication, then there are lesser drainage procedures. But these are preferable for effusions that are peripheral, okay, and inferiorly located on the chest wall. Hence the Eloisa flap procedure. I may not go into greater detail about it, but what it's supposed to achieve is an open drainage of the chest in these patients who will not be able to undergo a major aggressive surgery, so that it continuously drains. You can even send the patient home, it continuously drains, and you hope that the lung will ultimately expand and gradually close off that space. Thank you.